Good morning and welcome. My name is Marguerite Urban, and I am the principal investigator for the New York State Clinical Education Initiative Sexual Health Center of Excellence. I am here on June 6th of 2022, and this is the first day of our 8th annual New York State Sexual Health Conference. This is a virtual conference that will include live presentations 4 days of this week. But because of late breaking news with monkeypox, I'm recording this morning to post on our website to give up to the minute information about the current outbreaks of monkeypox 2022. So just to begin, this will be a brief presentation, and as background, monkeypox is a viral zoonosis. It was initially described in Africa. It's an infection caused by an orthopox virus and was first isolated in 1958 within a colony of monkeys within Africa, hence the name. The first human case was reported in the Democratic Republic of Congo in 1970. The virus resides in the same genus as variola virus and vaccinia virus, so the agent of smallpox and the virus used for the initial smallpox vaccine. And there are two strains known: a Central African strain and a Western African strain. The Central African strain generally has a more severe illness as compared to the Western Africa strain, and the current outbreak appears to be associated with the strain from West Africa. In background, the infection has been relatively uncommon. There are sporadic outbreaks reported, primarily in Africa. For instance, between 1970 and 1980, there were only 59 reported cases, though with significant mortality of 17%, and the cases were associated with exposure generally to animals. The animal reservoir remains unknown, but is thought likely to be among rodents, and humans and monkeys are thought to be incidental hosts. A smallpox vaccine prepared with vaccinia virus was found to be 85% protective from early studies conducted in Africa. The first human case in the Western Hemisphere was associated with an outbreak in the United States, and that outbreak was associated with imported prairie dogs. Those prairie dogs were thought to have acquired the monkeypox virus from other animals that they were housed with in their transport. Currently, there's a multi-country outbreak ongoing with more than 550 cases reported as of May 31st of 2022 in non-endemic countries without associated travel to Africa or any known exposure to animals that might be infected. Prior to this current ongoing outbreak, non-African cases were associated with travel to Nigeria primarily, or with a known contact with an infected person or animal. This is a figure taken from the European CDC, and these are data as of May 31st, 2022. And you can see the affected countries portrayed here. And what is shown in the table are countries that are non-EU, with a smattering of cases in Argentina, Australia, Canada, 321 cases in the EU. And then as you go down the table, you can see others reported. As of May 31st, there were 15 cases reported in the USA and 179 cases in the UK. I was able to find this morning more recent data from the UK as of 6/5/22. And so that number had increased to 302 reported confirmed cases. And a confirmed case in these data is a person with laboratory confirmed monkeypox by monkeypox specific PCR, or an orthopox virus specific PCR, which is later confirmed by sequences to be monkeypox. And the symptoms are need to have begun since March 1st of 2022. Here's another figure from the same data source, looking more closely at EU countries. And here's the breakdown of EU countries. So you can see here Spain is particularly affected, and Portugal more so than some other countries, but fairly widespread across the European Union. And here are data from the US. This is from the CDC's website. This was updated on June 3rd, so a little bit more recent than the European cases. And you can see the breakdown of cases among the states, with California and New York having the highest number of cases at 5 each. But each day there is a state or two that has been added as I've been following this. And this page on the CDC's website is updated fairly frequently. So the characteristics of the cases in May, to give you a little sense of the timeline. On May 7th of 2022, there was a case of monkeypox identified in the UK in a person traveling from Nigeria. So this fit prior exposed cases, as was typical, with some exposure to the virus thought to be in Nigeria. However, 1 week later, on May 14th, 2022, 2 cases of monkeypox were identified in one family unit in the UK, with no link to travel to an endemic area and no link to the May 7th case that had been reported in the UK. Within 1 week following that, so by May 21st, an additional 20 cases were identified in the UK, and now other European Union countries were also reporting cases, again, not linked to travel to endemic areas. There was a international news alert release, and the first case was reported in Massachusetts on May 18th of 2022. And that case was reported to have had travel to Canada. Early data internationally suggests that the cases are clustered among men who are reported to be gay, bisexual, or other men who have sex with men. And most of these in the UK literature have been reported to be between the ages of 18 to 49. And within the UK, where the largest number of cases have resided, most cases were reported to be from London. We do know that transmission can occur with contact with the virus from an infected animal, an infected person, or materials or fomites contaminated with the virus, or also across the placenta to a fetus. The contact could be through a bite, scratch, exposure to body fluids, or exposure to materials that have touched body fluids, and possibly also with respiratory secretions. Close physical contact, including sexual contact, has been associated with transmission, but it is unknown at the present time if the virus is actually spread through semen or vaginal fluids or simply close contact. Infectivity is thought to be from the onset of the illness until all lesions have crusted over. Those crusts have separated, and then a fresh layer of healthy skin has formed under the crust. The clinical manifestations include an incubation period where one is not thought to be infectious or contagious. This can range from 5 to 21 days, although typically is between 6 to 13 days. Based on serologic studies in Africa, asymptomatic infection may be common. Among those symptomatic cases, the classic illness is there is a prodrome, which begins with a flu-like illness with fever, chills, myalgias, headache, malaise, sore throat, cough, and adenopathy, followed by a fairly characteristic rash. The adenopathy generally develops with the fever 1 to 2 days before the rash, and it may be local, such as cervical, submandibular, axillary, or inguinal, or more generalized. The rash then develops, and that can be anywhere in the body, including in the oral cavity, so it may be in an enanthem or an exanthem. The lesions progress synchronously from macular to papular to vesicular to pustular to scabbing, and then ultimately to resolution. The lesions may characteristically umbilicate, so with sort of a central divot, or they may coalesce and become more confluent. Here are some pictures from the CDC website. The lesions are reported to be well circumscribed, fairly deep-seated, and often with a central umbilication, sort of a divot or a dot on the top of the lesion. They generally are relatively the same size and the same stage of development, and often have an erythematous base, as you can see in these pictures. This synchronous development differs from that seen with varicella virus, which would be another possibility for generalized vesicular rash. As I mentioned earlier, the fever generally begins before the rash. Lymphadenopathy is common, and this is a distinguishing feature from actual smallpox. And the disseminated rash tends to have more lesions on the extremities and face as opposed to the trunk. There are lesions on the palms and soles, often reported, and the lesions can be reported as painful and may become more pruritic during healing. Here's some other pictures from Visual DX or CDC showing you some more lesions. So you can see it could be scattered few lesions or more prominent lesions, which have been reported more typically in youth under the age of 15 with many disseminated lesions. This is also from the CDC of the progression of the rash. So the first lesions may develop in the mouth, in the tongue, and in the mouth. Then the macules in 1 to 2 days, which become papular by the 3rd day, and then vesicular, and then ultimately pustular, and then scabbing over between 7 to 14 days later. Differential diagnosis. So typically this is an illness characterized by flu-like illness and rash. So the differential would include smallpox, although this is considered eradicated, but remains a concern because of the possibility of use as a bioweapon. Varicella, of course, for any sort of vesicular rash. Herpes infections, herpes simplex in particular. Syphilis, which can have many manifestations, and including palms and soles and oral lesions. Molluscum contagiosum, which can have the characteristic divot. Disseminated fungal infections, which can also have sort of a pustular infection, especially disseminated cryptococcosis. The treatment is generally for mild illness, supportive care only. In the current outbreak, you could consider treatment in consultation with the CDC, and in those you would consider this would be in immune-compromised hosts, in a young population, especially under the age of 8, in a pregnant or breastfeeding patients, or possibly in some other complicated infection. The treatment options include antivirals. So there's a new antiviral that was approved for the treatment of smallpox in the US fairly recently. It's available from the CDC under emergency use authorization, known as tecovirimat. Cidofovir does have in vitro activity against monkeypox. There's no clinical data really supporting that. Brincidofovir has been approved for the treatment of smallpox, and so there's some extrapolation that perhaps that could be effective against monkeypox, although that has both of these have been associated with significant side effects in some small reports. And vaccinia immune globulin is available at CDC for emergency use for complications of vaccinia vaccination, but could also be used with emergency use for orthopox virus infections. I mentioned earlier that the first cases in the Western Hemisphere were associated with an outbreak among prairie dogs. And there was a report published at that time about the characteristics of 37 patients at that time. So rash was almost universally present. The median duration was 12 days. Fever was also quite common, 85%, with a median duration of 8 days. Chills also common. Lymphadenopathy fairly common, around 70%. A nonspecific headache and myalgias, 56 and 65%. And about 25% of these individuals required hospitalization, some with nausea, vomiting, and dysphagia, and one case with encephalopathy. The 2022 outbreak is really just beginning and so is not yet well described, but we do know both internationally and in the US, most cases have been among gay and bisexual men and other men who have sex with men, most but not all. Notably, there have been some atypical features reported in some initial formal publications and in some news reports. The rash has often started in the genital area. Some rashes have remained localized to the genital area. There have been mild or even absent prodromes, which has not been commonly reported in the past. There have been some cases with associated proctitis that has been significantly symptomatic. And the illness has been mild enough that patients are presenting to outpatient settings, including sexual health clinics, both internationally and the US, as opposed to presenting to emergency departments. And as I alluded to earlier, all specimens to date that we are aware of have been associated with the West African version of the virus with the milder illness. So just on June 3rd, late on June 3rd, the CDC released a formal report on the current outbreak, and they included data on the cases reported as of May 31st. So that was 17 cases at the time. The initial case, the Massachusetts case that I reported earlier, had actually developed an anogenital rash 3 days after international travel, which was May 4th. So before this had been reported internationally, which that was released on May 17th. That rash was described to be vesicular and then pustular. The patient sought care as an outpatient on 4 separate occasions, eventually requiring hospitalization due to pain from the rash. And the CDC report only says common causes are ruled out, which was presumably some STI testing. There was a second case also reported in a little bit of descriptive language from New York. That was a patient with an oral lesion. There was a perianal rash. That patient was tested and treated for STIs. The rash became pustular. The patient returned for care after that and was treated for a different STI. This case also developed symptoms on May 4th. And both of these cases were reported to the CDC after the international announcement about monkeypox occurring in non-endemic countries in mid-May. The clinical descriptions of the additional cases were included in a table format. And so, of course, rash really has been the hallmark of this and was reported at any point in the illness in 100% of those cases. At the illness onset, about 29% of these 17 cases. And you can see in the table here, so it's raw number followed by percent. And so the first column is at illness onset, second column is prodrome, and the third column is at any point. So you can see there were some systemic symptoms of fatigue or malaise in 3/4 of individuals, chills in about 70%, adenopathy in about 50%, and sore throat and cough 29%, and other, not further detailed, in 3/4. And then the rash locations were also described, and you can see there was some variability with arm, trunk, leg, face, hand. Hand was 35% and feet were 24%. Genital also 24%. So as of 6/3/22, the publication date, all patients were reported to be clinically well and being monitored for the time frame to end isolation. One patient was treated with the antiviral. Contact investigations were ongoing, and as of the time of the publication, there were 56 high-risk contacts identified, 117 intermediate risk contacts identified, and another 235 low or uncertain contacts identified. And these included both contacts within the patient's personal life and hospital contacts, healthcare contacts. The CDC has established definitions for case definitions for the outbreak and has developed an exposure risk assessment tool, which is available on the CDC's website. The laboratory response network testing protocols have also been established. So when evaluating or suspecting a case, it is CDC and all of the local and state health departments are appealing that possible cases should be reported to your local or state health department and a local infection control specialist to implement infection control practices. The health department will coordinate testing within the laboratory response network, and the testing will involve looking for the presence of virus in the lesions and possibly also looking for testing of blood. The New York State Health Department has issued a health advisory that was dated on May 20th. Diagnostic testing is available at the New York State Department of Health Wadsworth Laboratory and the New York City Public Health Laboratory. To facilitate that testing, you have to coordinate with your local health department, the state health department, or the city health department, depending on your jurisdiction. And there's very detailed instructions on how to obtain specimens in this health advisory, which is available on the internet, simply searching for New York State Health Advisory about monkeypox. As I said, the CDC has identified case definitions. So they have three possible definitions: a suspect case, which is a new characteristic rash, or meets one of the epidemiologic criteria and has a high clinical suspicion. A probable case, so no suspicion of other recent orthopox virus exposure and demonstration of orthopox DNA by PCR or other specific testing as detailed here, or antibody testing. And then a confirmed case, which is demonstration of actual monkeypox DNA through laboratory testing as described here. The epidemiologic criteria are within 3 weeks of the illness onset. The individual would report having contact with a person or people with a similar appearing rash or who received a diagnosis of confirmed or probable monkeypox, or had close or intimate in-person contact with individuals in a social network experiencing monkeypox activity, including a network of men who have sex with men, who meet partners through online or digital apps, or travel outside of the US to a country with confirmed cases of monkeypox, or had some sort of animal contact. There are also exclusion criteria. So if there is an alternative diagnosis, if a patient with an illness consistent with monkeypox but does not develop the characteristic rash, or where very high quality specimens are not found to contain any evidence of monkeypox. So what about an approach to exposed persons? So as I mentioned, in the current cases, there are contact investigations, and those contacts are been divided into 4 categories by CDC: high, intermediate, low, or no risk, to determine a need for monitoring and the possibility of post-exposure prophylaxis. Monitoring is recommended to happen for 21 days after the last exposure and includes an assessment for fever, adenopathy, and rash. If any symptoms develop, the individual is advised to isolate. And there's a fairly detailed recommendation about the monitoring procedures on the CDC's website. For prevention, it is recommended, of course, to avoid exposure. So to practice infection control precautions in hospitalized or healthcare settings, to have hand hygiene. The healthcare recommended personal protective gear is a gown, gloves, eye protection, and N95 mask. Post-exposure prophylaxis is a possibility, and pre-exposure prophylaxis is also a possibility and has generally been done for those who work with orthopox viruses or who, through their employment, are at high risk of exposure. For post-exposure, the recommendation is ideally, this is theoretical benefit, but ideally to do within 4 days. We do know from the early studies that smallpox vaccine through vaccinia virus was 85% effective. There are other smallpox vaccines now available, as shown here. So the NYS is an attenuated virus approved by the FDA to prevent both monkeypox and smallpox. And the ACAM 2000 is a live virus vaccine, which is not attenuated. So there is some possibility of side effects from that and even transmission. And that's approved to prevent smallpox and has theoretical benefit of preventing monkeypox. So in conclusion, this is sort of a brief overview of what is known today. There are ongoing outbreaks in multiple non-endemic countries. It is important to maintain a high index of suspicion in the appropriate clinical and epidemiologic scenarios. We do know that individuals who have presented to date have had some atypical manifestations, including genital rashes, some cases with only rash and without prodrome, and some have been presenting to sexual health clinics. So for those of us who practice sexual health care, and in particular are familiar with looking for syphilis and herpes, we really want to keep this in mind. It is important to involve your local or state health department early if a case is suspected. We do know that there's still much to learn, so we'll need to be attentive to new alerts and really updates, because this is a very, very recent outbreak, really publicly reported for less than 3 weeks. And just an important comment about stigma. This initial outbreak has been reported primarily, but not exclusively, among men who have sex with men. To date, we don't know if there's frank sexual transmission, but we do know that the virus is quite contagious with close contact and does not distinguish based on sexual behavior or sexual identity. And so really, this is the IDSA and HIV MA position statement that stigma has no place in public health, and we really want to avoid stigma as we approach this outbreak. It is important that we stay current. These are two possible resources, the CDC and the NCSD website, which both have valuable and up-to-date and continuously updated monkeypox sort of command centers, as NCSD has phrased it. So thank you for watching, and CEI will also be keeping a close eye on this and developing other trainings that will be CE approved to offer through our regularly scheduled programming. And as always, if you have questions about STIs or other CEI related topics, you can call the CEI line 1-866-637-2342. And thank you for your attention.